Alright, so today is day 4. Um, we're just doing respiratory today, which is actually my weakest area. So we'll see how that goes. I have this rash on my hand. I don't know if you can see it. It's super red. I don't know what's going on here. Super itchy. Um, okay, so today we're gonna do the respiratory system. Let's look at what exactly is in the respiratory system. ABGs, asthma, review PED specific info in PEDS. Okay, so let's just make sure in pediatric we actually talk about asthma. And hemophilia, cystic fibrosis. I'm gonna add uh, asthma in here. Okay. Let's get started. Um, First of all, let's see information that all right, ABGs. Um, so I never liked how they taught us Rome. I think that's just stupid because um, we didn't get to understand the pathophysiology behind it. Um, but that's just me. I know a lot of people actually swear by it. Think it's like the best thing ever. Do we have a unit on fluid and electrolytes? Let's see. Oh, we do. Non-infectious upper respiratory problems. COPD versus asthma, acute respiratory failure, acute respiratory disease, PE, flail chest, TB, musculoskeletal, documentary, renal, disorder, GI, electrolytes, acid base, respiratory infection. We got a lot of sheet today. Hematology, reproductive, fertilization, prenatal, pregnancy complication, postpartum complications, postpartum complication 2, and newborn AMP 2.0, newborn wrist 2.0, neurovascular. Okay, so this is from 2 days ago. Alright, so I got all my respiratory shit out here. I was almost 3. Wow. So I assume we're gonna be done around 6. And then we can eat dinner, take a break around 7, and then take the exam until 9. Yeah, we'll see. I'll try to make it quicker. I don't like take a lot of time. Not even the point. Um, but I don't think. Let's see how many stuff we have to go through today. Respiratory. We have like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 things. Okay. And the lung sounds is like, yeah. So I want to group COPD with asthma, PE, PB, chest tube, basic vent. Okay. Chest tube. Is chest tube on here? Chest tube is on here. I want to look at the chest tube, like the water seal and everything. That is something I actually need to review. So let's take a look at what we have here. We have 1, 2, 3, 4, 5, 6. Damn, 6 pieces of paper. Okay. Um, let's take a look. So non-infectious, we got sleep apnea, obstructive sleep apnea. Um, what else? Epistaxis. Epistaxis is like bleeding of the nose, uncontrollable. Position forward. Prevent aspiration. Posterior nasal bleed. Posterior epistaxis is an emergency. Apply direct lateral position to nose for 10 minutes. Do not blow for the next 24 hours. Okay. Is that it? Non-infectious upper respiratory problem. That's it. So respiratory system, blood, hypoxemia is blood related. Hypoxia is tissue related. Ventilation is air. Perfusion, blood. Bronchitis. We got some stuff here. Emphysema. Obstructive lung disease. Airway obstruction. Mast cell. Holy shit, there's a lot of stuff mast cell does. Virtuous triad. Hey, my good friend, another triad. Virtuous triad, venous stasis, vein damage, and activation of clotting coagulation. Do we have a triad every day? Is that what's up here? We had Cushing's triad the first day with neuro. That is characterized by bradycardia, irregular respiration, and widened pulse pressure, I think. Let's see. What did I say? Bradycardia, irregular respiration, and widened pulse pressure. That's intracranial pressure. That's like neuro based. And then cardiac based, we got cardiac tamponade. And with that, we had Beck's triad, which is muffled heart sounds, decreased bradycardia, decreased blood pressure, and then jugular vein distension. And now we got Virtuous triad for what is it for? Virtual's triad, venous stasis, activation of blood coagulation, and vein damage. More like valvular damage, venous stasis. And I think Virtual's triad can cause PD, right? Yeah, deep vein thrombosis. So it can cause pulmonary embolus, PE. That's why we study Virtual's triad. All right. Pneumothorax, gas, and pleural space. And then we have pleural effusion, hemothorax, flail chest, and then sarcoidosis, autoimmune disease, atelectasis, which is diminished heart sounds due to partial collapse, complete collapse of lung, atelectasis. Okay. Oh, there he goes. So there's with respiratory system, there's obstructive and restrictive. They both cause shortness of breath, coughing. Obstructive is like asthma, bronchial, bronchial, bronchiolectasis, bronchiolectasis, COPD, and then restrictive is fibrotic scoliosis, muscular dystrophy, amyotrophic lateral sclerosis. Oh, ALS. We studied the first day. And then lateral sclerosis, spondylitis. Okay. So Pulmicort, glucocorticoid, no NSAIDs with glucocorticoids. Well, glucocorticoid has a lot of side effects. Osteoporosis, adrenal suppression, hyperglycemia. Yeah. Monteglucast for asthma, glucotrine. End result, decrease inflammation. And then we got LABA and SABAs for COPD and asthma. LABA is for COPD and asthma. So Salmeterol, SABA, albuterol. Both asthma. So both LABA and SABAs for COPD and asthma. Cool. And then there's acute bronchitis. Cool. Common cold, pneumonia, TB, rifampin. Rifampin can cause orange stuff, right? Isoniazid, rifampin, they're all hepatotoxic, cause orange skins. Pulmonary embolus, not good. Not good. COPD versus asthma. So COPD is chronic obstructive pulmonary disease, and it's composed of emphysema and chronic bronchitis. Emphysema is the collapse of, Yeah, it's a collapse of alveolar, with the destruction of it, and then bronchitis is the inflammation of the bronchus. Holy shit, this is loud. And then asthma is also a chronic disease. Um, Aspirin and NSAIDs can trigger. So no aspirin or NSAIDs. Eosinophil. Okay. Treat asthma with Saba, like albuterol, LABA, aspirin, and NSAIDs. So what are some NSAID drugs? Um, let's go to YouTube and then let's do NSAID picturize.
NSAIDs, which is short for non-steroidal anti-inflammatory drugs, are a class of medications used to treat inflammation and fever. In this mnemonic video, we'll teach you an easy way to remember the most important NSAID drug names, their clinical uses and side effects, so you'll be ready for the NCLEX. For today's video, we're headed to the Himalayan slopes where a man was having a blast riding his sled down the snowy slopes. This sled will serve as your memory anchor for the NSAIDs. SLED for NSAID, or the N-SLED, if you will. Like I mentioned before, NSAIDs stands for non-steroidal anti-inflammatory drugs. Unfortunately, these drugs don't share a common ending to their drug names, so we'll need to review each drug name individually. As the man was riding his sled down the mountain, this ibex rammed right into him. After all, ibexes are super common in the high Himalayan mountains like this one. Coincidentally, an ibex should help you remember the drug name ibuprofen. Ibex for ibuprofen, get it? Ibuprofen is probably the most common NSAID, one that I'm sure you've bought over the counter, you know, as the trade name Advil. But some of these next drug names might not be so familiar to you, so let's move on. In a failed attempt to dodge the ibex, the man has driven his sled right into a base camp for mountain climbers. Looks like one of the mountain climbers isn't doing so well. We'll talk more about him in a minute, but for now, notice the napkin tucked into his collar. Looks like he's getting ready to eat some of this hot soup to feel better. By the way, this napkin should help you remember naproxen, a napkin for naproxen, since they both start with nap, right? Again, naproxen is a relatively common drug that is often marketed under the trade name Aleve. Got that? Good. Let's keep going. Next, take a look at the kettle. The mountain climbers were heating up water in a kettle over the fire, or at least they were before the sled came crashing through. This kettle can help you remember the drug name ketorolac. Kettle for ketorolac. Easy, right? Ketorolac, often called by its trade name Toradol, is an NSAID drug that comes in an IV formulation. This makes it particularly useful for treating post-surgical pain, as this NSAID is often a safer alternative to opioids. I mentioned we were in the Himalayas, but where exactly? Take a look at that sign pointing towards India. Part of this mountain range runs through India, so it makes sense to have a sign and an Indian flag to help orient the climbers. This sign pointed towards India should help you remember the drug name indomethacin. Get it? India for indomethacin? Indomethacin is an NSAID drug generally used in a pediatrics context to close a patent foramen ovale. This detail isn't that important to know for the NCLEX, just remember that indomethacin is an NSAID drug and you'll be set. I mentioned before how the sick man here is getting ready to eat some soup. Let's take a closer look at the soup, specifically at the celery in the soup. This celery should help you remember the last NSAID drug name we'll cover, celecoxib. Celery for celecoxib. It's the celecoxib celery. With the drug names out of the way, let's move on to how these drugs are actually used in the clinical setting. As the sled came crashing into camp, it landed right in the explorer's fire and is now going up in flames. Good thing the mountain guide had a fire extinguisher on hand to put out the flames. Here at Pixorize, we use a fire extinguisher as our recurring symbol for anti-inflammatory drugs, because a fire extinguisher puts out flames just like anti-inflammatories put out inflammation. NSAIDs have potent anti-inflammatory properties. I mean, they are called non-steroidal anti-inflammatory drugs for a reason. We won't go into too much detail on the mechanism here, but in a nutshell, NSAIDs inhibit the COX enzymes, which are responsible for synthesizing inflammatory molecules like prostaglandins in the body. So, by stopping the COX enzymes, there isn't as much inflammation. Got that? This anti-inflammatory effect makes NSAIDs useful in treating inflammatory diseases like arthritis or ulcerative colitis. Getting hit by an ibex is an extremely painful experience, as you can imagine. Just take a look at the guy's face, wincing in pain. This pain should help you remember that NSAIDs are used to treat pain, specifically mild to moderate pain. Different NSAIDs will be used in different situations, but in general, over-the-counter NSAIDs are great for treating the everyday aches and pains like headaches, menstrual pain, muscle cramps, and so on. You probably already know this, so let's just move on. One of the mountain climbers has fallen sick during this climb. We'll talk about why in a moment, but he sure is spiking a high fever. I mean, the thermometer is reading super hot. This high thermometer can help you remember that NSAIDs are used to treat fever. NSAIDs have antipyretic properties, meaning they lower fevers. Now that we've talked about when NSAIDs are given, let's move on to some of the side effects and adverse reactions of NSAIDs. When the ibex rammed into the sled, its horns caught on the man's shirt, creating a big gaping hole right over the belly. You know, the way this hole in the shirt is right over the stomach reminds me of how NSAIDs can cause holes in the gut wall, known as gastrointestinal ulcers. Yep, the most important side effect of NSAIDs to know is that they can increase the risk of GI ulcers, especially in the stomach and duodenum. Technically, NSAIDs reduce the protective mucosal lining of our gut walls, leaving them more susceptible to damage from stomach acid. GI ulcers can be prevented by taking NSAIDs with plenty of food and water, taking only the recommended dose, and by avoiding alcohol, since alcohol can promote ulcer formation. Keep an eye out for symptoms like nausea, abdominal pain, or bloody stools, because these are potential symptoms of GI ulcers. Not only did the ibex's horns pierce through his shirt, but they also cut the man's skin so that he's bleeding. This should help you remember that NSAIDs can cause bleeding. We talked earlier about how NSAIDs Not only does our sick friend have a fever, but he is also coughing up a storm. The way he is coughing should help you remember that NSAIDs can cause bronchospasm. This is really only an issue for patients who have pre-existing respiratory conditions, such as asthma. NSAIDs can exacerbate the asthma, so be cautious in giving NSAIDs to asthmatic patients. Oh no, not the soup! The NSAID sled crashed into the fire, knocking over the soup that was going to be given to the sick guy. The soup has celery, like we talked about earlier, but it was also full of beans that are now spilling out onto the ground. Here at Pixorize, we use falling beans as our symbol for nephrotoxicity. Let me explain. The beans are shaped just like a kidney, and they are falling, just like kidney function falls in nephrotoxicity. Get it? Use these falling beans to help you remember with known kidney trip, not only with a fire extinguisher, but he also brought along tons of extra water, which they used in the kettle and to make the soup. When you think of all this extra water, remember that NSAID may notice because a little extra fluid down to the bottom of what made this hiker so sick. Turns out he got bit by a tarantula. Take a look at the bite marks on his arm and the tarantula still sitting right there next to him. At Pixorize, the tarantula is our recurring symbol for teratogenic drugs. It's the teratogenic tarantula. NSAIDs should not be given in pregnancy for this mnemonic on the NSAIDs. Let's
Okay, that was actually pretty good. Okay, so, uh, well, the reason why I really want to go over NSAID is because I've gotten questions wrong on there in regards to which drugs are NSAIDs. Because I know you're not supposed to give NSAIDs to, um, like bleeding or, well, now asthma. But I didn't know which drugs were NSAIDs other than the classic ibuprofen and naproxen. And so I think this would really help me in terms of understanding which drugs are NSAIDs and which drugs are not. So we can like easily determine which things. Okay, so let's go into drugs. We should have NSAID uploaded. Okay, so um, all right, so anti-inflammatory. Ibuprofen, GI bleed, that's a side effect, and also just bleeding in general. We have kidney failure, nephrotoxic. This one, so it's a Cella something, and then also ketorolac. And then I forgot the rest.
The next one. Just be aware that acetaminophen is preferred over NSAIDs for pregnant women. All right, that's all for this mnemonic on the NSAIDs. Let's recap and get back to the slopes. NSAIDs, short for non-steroidal anti-inflammatory drugs, are a class of medications that include the drug names ibuprofen, naproxen, ketorolac.
Oh yeah, naproxen. And that causes, treats, it's an antipyretic, and it also can cause bronchospasms. Another drug can cause bronchospasm is beta blockers.
Indomethacin and
Indomethacin. There we go.
And celecoxib.
Celecoxib.
Clinically, NSAIDs are used to treat mild to moderate pain, reduce inflammation to treat diseases like arthritis, as well as to reduce fevers. Side effects of NSAIDs include GI ulcer formation and an increased risk of bleeding. NSAIDs can cause bronchospasm to exacerbate asthma. NSAIDs can cause kidney damage or nephrotoxicity. As well as fluid retention. And finally, NSAIDs are teratogenic and should be avoided in pregnant women, especially during the third trimester. And now we're actually done with NSAIDs. Remember to sled safely, guys.
Yeah, NSAIDs are a big important part of all medications. Okay. Let's start. Okay. Or do acid base later. Yeah, fluids and electrolytes. Okay. Good. Arterial blood gas. Well, we know that pretty well, I would say. Um, to be honest, arterial blood gas is more, uh, that's more for fluid, acid and base balance, but we can cover that here too. Um, so ABGs. So normal values, pH should be 7.35 to 7.45. Partial pressure of CO2 should be 35 to 45, I believe. Yeah, 35 to 45. And then bicarb, which is HCO3, should be 22 to 26. And then carbon dioxide is acidic. Well, bicarb is basic, and so from that we can infer everything else. Let's try this acid-base worksheet actually. It's right here. So 7.24, this is acidic. 45, this is super high. Bicarb 20 to 26, this is normal. Acid-base balance. So we have respiratory acidosis, uncompensated. 7.35, 7.45, this is alkalotic. 35 to 45, this is increased. 22 to 26, this is increased. So it is partially compensated metabolic alkalosis. Alkalosis partially, yep. 7.35, 7.45, this is alkalotic. 22 to 26, this is about the same. And then this is 35 to 45. So we have respiratory alkalosis and this is uncompensated. 0.35, so acidosis 22 to 26. This is high. 35 to 45, this is also high. So this is respiratory acidosis. 22, 26 is trying to compensate. It's partially compensated. Respiratory acidosis partially compensated, yep. 35 to 45, acidosis 22 to 26. 35 to 45. This is the same, so this is uncompensated, and this is metabolic alkalosis. Alkalosis uncompensated, good. 6. 35 to 45, 7.35 to 45, 22 to 26, 35 to 45. So again, this is uncompensated metabolic acidosis. Okay. I think I know my acidosis and alkalosis, at least metabolic versus respiratory, pretty well, and compensated versus uncompensated pretty well. It's such a good song. But I like the previous song a lot. little section called asthma versus um, asthma versus uh, our good friend COPD. I like that one a lot. Okay, theophylline is a drug for asthma. Theophylline you do not mix with something. Verapamil. No digoxin with verapamil either. Am I right or am I correct? Oh. Verapamil, nifedipine, no theophylline or digoxin. something yesterday. Oh, pericarditis that can cause, um, no, MI that can lead to pericarditis. Like recent MI that can lead to pericarditis. Yeah, post MI that can lead to pericarditis. If you think about it, if you have chronic emphysema, or if you have emphysema and chronic bronchitis, your lungs are not in a good place. And so if your heart is trying to pump blood into the lungs via the right ventricle, it's going to back up, and therefore you're going to have right-sided heart failure. And with right-sided heart failure that we talked about yesterday, you're going to have edema, jugular vein distension, um, and edema. So that makes a lot of sense, actually. Asthma, COPD, um, acute respiratory failure.
Okay, guys, so we just went into the respiratory failure, the ventilation change problems down into your lungs. And that trouble can come from having a decrease in any OP, just the mechanic in that ventilation. Okay.
Oh my god. Come on.
Two people are admitted to the emergency department. Mike, a 55-year-old man, presents with shortness of breath, high fever, and cough. A chest x-ray was ordered, and it showed a right lower lobe infiltrate, which is suggestive of pneumonia. He was then started on IV antibiotics, but the following day, Mike became hypoxic and hypotensive. Because his hypotension didn't improve despite intubation, IV fluids, and vasopressors, he is diagnosed with septic shock. Next, a repeat x-ray detected newly developed bilateral alveolar opacities, heart echography ruled out heart failure, and arterial blood gas analysis revealed a PF ratio of 109 milligrams of mercury. Then there was Donna, an infant delivered by cesarean section at 36 weeks gestational age, with an APGAR score of 9 at birth. A few hours after delivery, she develops tachypnea, chest wall retractions with nasal flaring, and tachycardia. Aside from increased work of breathing, her physical examination findings are normal. A chest x-ray was ordered, and it showed diffuse reticulogranular ground glass appearance with air bronchograms. Now, both people are in respiratory distress. But first, a bit of physiology. Normally, when you breathe in, the air reaches the alveoli, which are made up of two types of pneumocytes. First, type 1 pneumocytes are thin and have a large surface area that can facilitate gas exchange. More important for the exams are the type 2 pneumocytes, which are smaller, thicker, and have the ability to proliferate in response to lung injury. They are in charge of making a fluid called surfactant, which contains various phospholipids. This lets it act like...
This is also why we give premature infants Betamax.
droplets of oil that coat the inside of the alveoli, decreasing surface tension, so if it's missing, the alveoli will collapse. These cells also act like stem cells, meaning they can give rise to type 1 cells and type 2 pneumocytes. Okay, so acute respiratory distress syndrome, or ARDS, is characterized by rapid onset of widespread inflammation in the lungs, which can lead to respiratory failure. ARDS is not a primary disease, as it is usually triggered by conditions like sepsis, aspiration, trauma, and pancreatitis. Now, ARDS...
Are we talking about acute respiratory distress syndrome? We're talking about acute respiratory failure.
starts when these conditions cause alveolar damage, and a high yield fact is that the injury triggers the pneumocytes to secrete inflammatory cytokines like TNF-alpha and interleukin-1. This subsequently leads to neutrophil recruitment, and they will release toxic mediators like reactive oxygen species and proteases, which will damage the lungs even more. You'll need to know that the main site of injury is the alveolar capillary membrane, which becomes more permeable, causing fluid to move into the alveoli, resulting in pulmonary edema. This fluid can impair gas exchange, leading to hypoxemia. Furthermore, the edema can also wash away the surfactant coating of the alveoli to the point where it can't reduce surface tension anymore, and as a result, the alveoli collapse. And finally, dead cells and protein-rich fluids start to pile up in the alveolar space, and over time, it forms this waxy hyaline membrane, which look like a layer of glassy material. Individuals with ARDS present with serious symptoms and signs that require urgent. The inflammation process and impaired gas exchange lead to fever, shortness of breath, tachypnea, chest pain, hypotension, hypoxia, and cyanosis. More often than not, ARDS will lead to shock due to hypotension. The excess fluid in the lungs can cause a crackling sound called rales during auscultation, which is the sound of collapsed alveoli popping open with inspiration. Keep in mind that additional symptoms might provide clues to the underlying cause. For example, epigastric abdominal pain radiating to the back along with a history of gallstones indicate acute pancreatitis. Diagnosis of ARDS is typically made when the individual presents all of the next 4 criteria, which you should definitely remember for your exams. First, the symptoms have to be acute, meaning an onset of 1 week or less. Second, and particularly high yield, a chest x-ray or CT scan shows opacities or whiteout in both lungs, which is due to pulmonary edema. The third is what's called the PF ratio. It's the partial pressure of oxygen in the arterial blood divided by the percent of oxygen in the inspired air, also called the fraction of inspired oxygen. In ARDS, gas exchange is defective, so the PF ratio is below 300 millimeters of mercury, and the lower this ratio gets, the more severe the condition. Fourth, the respiratory distress must not be due to cardiac causes, like heart failure. Often this is assessed by using an echocardiogram to look for evidence of heart failure, like an ejection fraction below 55% in systolic heart failure, and abnormal relaxation of the myocardium in diastolic heart failure. Another clue is the pulmonary capillary wedge pressure, which is measured by inserting a catheter into a small pulmonary arterial branch. In heart failure, this is elevated because more blood remains in the left side of the heart and it prevents pulmonary venous return. The blood backs up into the pulmonary vessels, and the increase in pressure pushes fluid into the interstitium of the lungs, resulting in edema. In ARDS, the pressure is normal since the edema is caused by leaky capillaries instead of increased pressure. Treatment of ARDS ultimately comes down to treating the condition that triggered it. However, the most important initial step is supportive care, like supplemental oxygen or mechanical ventilation. A high-yield fact to remember is that it's vital to maintain positive end expiratory pressure, which is where the pressure in the lungs is kept slightly above atmospheric pressure, even after exhalation, because this prevents the alveoli from collapsing. It's also good to have low tidal volumes to prevent overinflation of the damaged alveoli. Another important thing to watch out for is positive pressure ventilation, which can cause compression of pulmonary vessels, which leads to pulmonary hypertension, decreased pulmonary venous return. This will reduce cardiac output and hypotension might worsen. Now, even with supportive care, the macrophages clean up old cell debris that attract and activate fibroblasts, which are cells that secrete collagen and form scar tissue in the alveolar walls. If there's enough scar tissue, it can still lead to a decrease in lung compliance, or the ability of lungs to expand and come back to their original size. Remember that this means the individual will have residual symptoms all of their lives. Next, neonatal respiratory distress syndrome is a disease of the newborn caused by a deficiency of surfactant. This results in alveoli that can't stay open, and the newborn has to work hard to breathe, resulting in the development of progressive and diffuse atelectasis. Now, there are some risk factors associated with the disease that are commonly tested. First, there's prematurity, usually because the lungs are not mature enough to produce surfactant. Levels in the infant, corticoids. At birth, the newborn might be ascendant with the O2 pressure lead to heart failure. Now, you'll The inflammation process of breath cyanosis.
Sure, pneumonia is droplet precaution. Droplet, yeah. TB is um, airborne. Oh, night sweats is TB, yes. Confusion. I like how we already talked about pleural effusion. Um, pleural effusion can be right, left side of heart failure can lead to pleural effusion. Lots of things can lead to pleural effusion, actually. Let's see if we have like something about pleural effusion. So why nothing about clotting factor, but then D dimer is a clotting factor, or something about like clotting? What? Alter place. I don't know what another one could be. I think we learned about that. That's for stable vagina. It's probably for myocardial infarction. Alteplase and yeah, streptokinase, right? Thrombolytic. Um, bonus for angina. Also for heart attack. Okay, so we have thrombolytics like that, and then anticoagulants like warfarin. Okay. Uh, precaution with vitamin K. What else? Bleeding precaution. All right. So speaking of bleeding, let's review our NSAIDs again. So to my anti-inflammatory, ketorolac, Indo something, and then there's a cell something from Spirited Away. Indo something oxygen or something. Celedoxin, Dixon, something, and then it can cause bronchospasms, teratogenic, bleeding, GI ulcers. Methiosin, celecoxin, ketorolac, hypertension is bad for the kidneys, nephrotoxic, GI bleeding, ibuprofen. Well, I already know ibuprofen. Antipyretic bronchospasm, right? Ibuprofen is very, very important, I think. I need to know, like, there's also naproxen. Okay, so we just talked about PE. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6. You know what? We're not that bad. It's only been an hour, right? How long has it been? It's been like an hour and 30. So I assume like we'll finish by 5:30, like 6. Yeah, 5:36. And I got like half the page ish. So perfect. And the rest should be pretty easy. Oxygen delivery devices, bronchoscopy. Yeah, the rest should be pretty easy. Let's take a little break. I'm gonna take a 10-minute break. Hey Google, set a timer for 10 minutes.
Okay, 10 minutes. Starting now.
Okay, I'm back. Actually, let's finish up my milk tea. Ah, ah. Oh, that's lame. Oh, goodness. Ah, good milk tea. Good milk tea. Okay. Let's talk about hemothorax and pneumothorax. Hemothorax is basically when blood's inside the lung, and pneumothorax is when air is inside the lung. But that's a little sneak peek. Let's see. Theophylline for asthma. Oh yeah, theophylline for asthma. I mean, there isn't a lot of information here in regards to those respiratory infection and the respiratory system. Yeah. Okay. So pleural effusion accumulation treatment for restrictive inflammation, autoimmune fluid buildup, diuretics. Yeah. Hemothorax is, I mean, I don't know. Let's look at it. Let's look at it. Hemothorax. How long is that? 6 minutes? Okay. Yeah.
With pneumothorax, pneumo refers to air and thorax means chest. So a pneumothorax is when there's air in the chest. More specifically, air in the space between the lungs and the chest wall, called the pleural space. The pleural space lies between the parietal pleura, which is stuck to the chest wall, and the visceral pleura, which is stuck to the lungs. The pleural space normally contains a lubricating fluid that helps reduce friction as the lungs expand and contract. Pressure within the pleural space.
Oh, actually, just kidding. We have something here about pneumothorax and hemothorax. Awesome. Let's start here. Pneumothorax. Ah. Tension pneumothorax occurs when air enters the pleural space during inspiration. Okay. So let's look at causes of leak. Chest trauma, COPD, asthma, cystic fibrosis. I would say probably chest trauma. I would not bet on COPD asthma. I think chest tube is used for both fluid and air. Yeah. Oh, why is that so good? I don't understand. I don't understand. Now, next thing, let's talk about chest tube, since we just mentioned it in both Nemo and hemothorax. Um, okay, so rapid bubbling equals air leak. And tape with that. No tidally equals check kink and breath sounds. No bubbling equals no suction. So check tubing and suction, and then chest tube DC. That's bad news. Immediately sterile water. And then chest tube pull from client. You cover site. Cover with sterile dressing. Tapped on 3 sides. Or taped on 3 sides, sorry. And then prepare insertion. Okay. Actually, I want to do this one first. Might be able to finish it around like 5:15. Then we can start like 6 for everything else. Or we can just start, we can just finish everything before 9. Pleural effusion. Nope, does not talk about that here. I mean, it talked about it here. Pleural effusion, accumulation of large amount of fluid in the pleural space, and the treatment for that is diuretic and also thoracentesis. But it seems pretty basic information to me.
Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through pleural effusions, and you can find written notes on this topic at ZeroToFinals.com/pleural effusion, or in the respiratory section of the Zero to Finals medicine book. Let's jump straight in. A pleural effusion is a collection of fluid in the pleural cavity, and this is a cavity between the lung and the chest wall. This can be either exudative, meaning there's a high protein count of above 3 grams per litre of protein, or transudative, meaning there's a relatively lower protein count of less than 3 grams per litre. Whether it's exudative or transudative helps you to determine what the cause of the pleural effusion is. Exudative causes are caused by inflammation, and the inflammation results in protein leaking out of the tissues into the pleural space. Ex meaning moving out of. Think of the causes of inflammation when you want to think of the causes of exudative pleural effusions. And this is things like lung cancer, pneumonia or lung infections, rheumatoid arthritis, and tuberculosis. Trans and tuberculosis. Transudative causes relate to fluid moving across into the pleural space. Trans meaning moving across. And you can think of the causes of fluid shifting, which would be congestive cardiac failure, hypoalbuminemia or low albumin level in the blood, hypothyroidism or low thyroid level, Meigs syndrome, which is a triad of a right-sided pleural effusion, ovarian cancer, and ascites. So what's the presentation of pleural effusions? Well, because they're taking up space in the chest and making it more difficult for the lungs to fill with air, the patient will present with shortness of breath. They'll be dullness when you percuss over the area of the effusion, because there's no air to cause a resonant sound to percussion. When you listen with your stethoscope, you'll find there's reduced breath sounds in this area because air's not getting in. And if you get a massive effusion, that fluid will push the mediastinum and the trachea across inside the chest. So when you feel over the trachea, you'll find tracheal deviation. What investigations can we do with a pleural effusion? Well, the main investigation is a chest x-ray, and this will show blunting of the costophrenic angle. So the angle down in the corner between the diaphragm and the chest wall will be blunted rather than sharp. You might find fluid in the lung fissures. Large effusions will have a meniscus where there's curving upwards where it meets the chest wall and mediastinum. If there's a massive effusion, you might see tracheal and mediastinal deviation. The next investigation you would do if you find a pleural effusion is to take a sample of the pleural fluid by aspiration or by putting in a chest drain. And this is required to analyze it for things like protein count, the cell count, pH to check the acidity, glucose, LDH, and microbiology testing to try and grow bugs to see if there's any infection in the effusion. So how do you manage a pleural effusion? Well, if you've got a small pleural effusion, then conservative management may be appropriate, as it might just resolve with treatment of the underlying cause. So for example, if you treat the chest infection, the effusion might resolve on its own. Larger effusions often need aspiration or drainage. So pleural aspiration is one option, and this involves sticking a needle on the end of a big syringe through the chest wall into the effusion and aspirating the fluid. And this can temporarily relieve the pressure that's caused by the effusion, but once you relieve it, the effusion may reoccur and repeated aspiration may be required, particularly if there's an ongoing underlying cause like a lung cancer. Putting a chest drain in is a useful way to drain the effusion and prevent it from reoccurring.
Is a chest drain a chest tube? Yeah, it's the same thing.
Because as more fluid enters the pleural space, an infected moving pneumonia improves because there's low bacteria. Drain. Don't forget there's plenty of other resources on the Zero to Finals website, including loads and loads of notes on various different topics that you might cover in medical school.
In medical school. Shit. So, pleural effusion, to my understanding, is just like it's just fluid in the lungs, and that can be caused by like pneumonia or TB, which one of the biggest signs of TB is night sweats. If I can find my mouse. Okay. And then pneumonia is droplet precaution as opposed to airborne precaution. And then you have all the drugs that comes with TB that's liver toxic or hepatotoxic. Pneumonia, confusion. Yeah. Okay, feel pretty good about bronchoscopy. Lung sounds. Yeah, but we can do some lung sounds. I think I'm done taking notes for today. There's still a big section over here. Just like all the other days, I have like leftover sections. I think neuro had the least amount so far. Only this. Yesterday cardiac, I had a big section, like a big half over here, and the bottom is all empty. And today is not that much actually. I only have like about a quarter page left for additional notes that I might want to take later on. Yeah. Okay. I'm done with today's stuff. Let's look at bronchoscopy and see if we need to take any notes on that.
Bronchoscopy, examination of your airways. You will be called from the waiting room and take a seat in the examination room.
They perform a bronchoscopy to look for and diagnose problems inside your lungs. Your nose and mouth are points of entry for air to move in and out of your lungs through your trachea or windpipe and bronchial tubes. With each breath, your lungs inhale oxygen and exhale carbon dioxide. This exchange of gases is the way your body gets oxygen into your blood. A bronchoscopy may be done to look for and possibly retrieve a foreign object that may have been inhaled instead of swallowed, investigate a persistent cough or a cough producing blood, obtain a mucus, tissue, or liquid sample from inside your lungs, or evaluate an abnormal chest X-ray or CT scan. Before your procedure, you will receive medication to help you relax and chest X-ray or CT scan. Before your procedure, you will receive medication to help you relax and minimize coughing. An intravenous line will be inserted for additional medications. Your heart and blood pressure will be monitored, and you will be given extra oxygen during the procedure. You will be given either a local anesthetic to numb your throat or general anesthesia. During the procedure, your doctor will slowly thread a bronchoscope through your nose or mouth, down your throat, past your vocal cords, through your trachea, and into your bronchial tubes. He or she will carefully examine the lining of your airways and may take samples for laboratory examination or remove a foreign object. After the procedure, you will be taken to a recovery area. If a biopsy has been taken, you will likely have a chest X-ray before you leave the hospital. Your doctor will send any mucus, liquid, or biopsy.
There you go. There's a bronchoscopy. NPO 8 to 12 hours. Upright position. What else? Gag reflex bleeding and respiratory. Okay. Watch for gag reflex, bleeding, and respiratory status, along with vital signs. Cool. And it's pretty straightforward. Just the 8 to 12 hours of NPO. That's all I needed. Okay, oxygen delivery devices. I mean, I'll watch the video on it.
Hello everyone, welcome to Nursing Essentials. In today's video, we're going to do a quick review of basic oxygen delivery systems. There was actually a question on our community tab about this. This is a question right here. So if you haven't done so already, make sure you subscribe to our channel so you don't miss out on questions like this. So before we get started, let's define the fraction of inspired oxygen, or FiO2, which is the fraction of inspired oxygen by volume in the inspired air. In plain words, the amount of oxygen that goes into the lungs when you have air. That being said, let's 40%, and you can use an oxygen flow rate that goes from 1 up to 6 liters per minute. Now, the clinical applications for the nasal cannula, this is going to be pretty much a low oxygen source at the bottom there. These are the nasal operations to keep in mind with the nasal cannula. It can be easily tolerated, which is a good thing. Applying to humidification as prescribed, and check the wider levels if this is the case. Breathe. For example, if you need to provide an FiO2 to report at the bottom of the mask. This is what the mask looks like. Then you would definitely go with a face mask. Let's review the simple face mask. This is a plastic face mask that is going to cover the nose and mouth, and it allows for oxygen to enter directly to a port at the bottom of the mask. This is what the mask looks like. Needs a face mask, and why not a nasal cannula? Well, if the patient requires a higher fraction of inspired oxygen, then the base goes from 30% up to 60%, and you can use an oxygen can be delivered goes up to 60%, and you can do so in increments ranging from 24% up to all the way up to 60% filled with oxygen. You have one-way valves on both sides that actually prevent the rebreathing of anxiety in the client who feels claustrophobic. Ensure that the valves and flaps are intact and functional during each breath. That is, the valves should open during expiration and close during inhalation. This is a non.
I'm okay on that. Okay, that's the lung sound reviews. Oh, that's a cool little thing. Well, I like this one. I hear friction row. Oh, okay. The fuck is that? Wheezing? Fine crackles. Strider. This is wheezing. Vesicular. Is this wheezing? Low pitch wheeze. Okay. Oh, this is wheeze. Cool. That one is like both-sided weakness, muscular, both-sided, like bilateral weakness, aspiration. Yeah. Okay. Cool. Wow. Finished it before I thought I would. I guess we can go into the question portion right now if I want to. I can take like I can take a short little break. Let's take a break until 6:30 or 5:30, and then I'll come back. Hey Google, set a timer for 30 minutes.
Sure, 30 minutes. And we're starting now.
Oh. Okay. We're breaking that. Yeah, we're breaking.